Welcome back, Thrani. I'm Joe B. Today I'll show you how to correct a glenohumeral internal rotation deficit through a combination of thrust and non-thrust joint mobilization and exercises. Let's dive in. According to Orthopedic Physical Therapy publication of 2021, a glenohumeral internal rotation deficit, or GIRD, is a condition seen commonly in overhead athletes and general population that results to tightness of the posterior joint capsule and rotator cuff, resulting to changes in the glenohumeral joint center of rotation. The cause of this can be due to repetitive overhead and maximal external rotation. A GIRD or GIRD can bring about a loss of shoulder internal rotation range of motion of 18 to 20 degrees compared to the opposite shoulder or normal values. There will also be posterior shoulder tightness and scapular dyskinesia. To treat, because of the repetitive overhead motion and maximal external rotation, the humeral head is translated more anteriorly, therefore we want to move it posteriorly. Because of this, we want to do the glenohumeral internal rotation relocation technique. The position of the patient will be sitting at the edge of the table. The treated shoulder will be in such a way that the right hand will be at the patient's waist. The therapist will be on the treated side with the right dominant hand at the anterior shoulder and the left hand behind the patient's right elbow. From there, the patient is asked to press the elbow against the therapist's left hand hard and quick. Once that is achieved, the therapist will deliver a high-velocity, low-amplitude thrust through the right hand to translate the shoulder or the humeral head posteriorly. This can be done for 1 to 2 reps. To loosen up the sternoclavicular and acromioclavicular joint, the therapist can also perform the clavicular distraction. The position of the patient will be in supine with treated side in line with the edge of the table. Shoulder abducted 90 degrees and elbow flexed 90 degrees. The therapist will be on the treated side with the left hand holding the wrist, while the right hand grasps the proximal forearm. From there, a lateral distraction is delivered through the right hand up to the limit of the range to take up the slack. That would be grade 4 mobilization. After that, the therapist provides a high velocity, low amplitude thrust, or a grade 5, to distract the clavicle. This can be done for 1 to 2 reps. To improve scapulothoracic joint downward rotation, the position of the patient will be side-lying on the left side with the treated scapula uppermost. Arms relaxed at the sides, or if tolerated, placed behind the back. The therapist will be facing the patient at the level of the shoulder. Pillow can be placed between the patient's chest and the therapist's belly. The left hand, first dorsal web space, will be placed on the inferior scapular angle, while the right hand, lateral 3 fingers or 4 fingers, can be placed at the scapular spine. From there, the therapist will bring her left shoulder inferiorly and medially to result to the left hand gliding the inferior angle of the scapula towards downward rotation. The right hand will pull the spine of the scapula laterally from the spine. This position is held for 30 seconds for 3 to 5 reps. To perform glenohumeral posterior glide, the patient will be in supine with treated shoulder flexed to a tolerable range and elbow flexed. The therapist is on the treated side with the patient's lateral arm at the therapist's belly. The left hand is placed on the anterior axilla while the right hand cups the elbow. The therapist flexes her trunk forward or bows to cause glenohumeral distraction. After that, the therapist bends both knees or squats to cause a posterior glenohumeral glide. The position is held for 30 seconds for 3 to 5 reps. Exercises can be provided like a cross-arm stretch for flexion and internal rotation retention of motion. For functional hands behind the back motion, a stretch can also be performed for that. All of these exercises are held 30 seconds hold for 3 to 5 reps. The assessment for GIRD can start from history taking, as these patients will complain of an insidious onset shoulder pain of 1 to 3 months with repetitive overhead and external rotation activities. When you check the posterior glide of the glenohumeral joint for flexion and internal rotation movements, you will notice hypomobility, not so much when you bow or distract the joint, but when you squat down, since that is when you check the posterior glide. But how do you fix limitation of motion from a shoulder injury related to vaccine administration or SERVA? Watch this video and find out. Thank you so much. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.